Good morning, good morning, good morning, and welcome to the Great Lakes Health Radio program on Power 96.5 FM and 1080 WUFO. Or you might be listening to us on your favorite streaming service. So, welcome. And thank you for listening, and thank you for following the Great Lakes Health Radio program. I'm your host this morning, Francesca Messiah. Kaleida Health, Manager, Community Health Improvement. And can I say I am so excited when you stop me in the community and tell me that you listen to the show. I love it. And what's the first question I always ask? Is there a program? Is there a topic we haven't covered that you would like to hear more about? And I mean that. So when I see you again, let me know. Before we begin our program today, safety tip for children. And we're focusing a lot on our focus, instead of like all children, because children, right, cover quite a span. We're looking at newborns, toddlers, and those who are beginning school years. And our guest for today is Ben Casper. Good morning, Ben.
Good morning, Francesca.
How are you?
Oh, I'm doing quite well, thanks. How about yourself?
Oh, wonderful. And Ben is a trauma, injury, and prevention specialist at Golisano Children's Hospital, and not a stranger to the show because we have addressed safety tips for children. But this time I said, let's just focus on a certain age group. But before we begin our interview, let me just give you a little bit of information on who is Kaleida Health. We are hospitals. We are not health insurance. You use your health insurance once you're in the hospital, but we're Buffalo General Hospital, Gates Vascular Institute, Golisano Children's Hospital, Millard Fillmore Suburban, Visiting Nursing Association. We have two long-term care facilities, and one is at High Point on Michigan, and the other DeGraff Memorial. And DeGraff is in North Tonawanda, where there's also an urgent care center there as well, emergency urgent center as well. We have throughout Western New York, south of Buffalo, north of Buffalo, clinics for adults, for children, specialty clinics for weight loss, um, orthopedic, and more. Visit our Kaleida Health website and let me spell Kaleida for you. KALEIDA Again, that's KALEIDA.org. So again, put that in your search engine and you'll see all the services, departments, everything. All righty. On with their show. So Ben, let's first start out with if you could briefly describe your department and why your department is important to the community. The name of your department, why it's important to the community.
Yeah, so I'm part of a team known as the Trauma Department. We're a level 1 trauma center accredited by the American College of Surgeons, which is the highest level of accreditation or verification that you can have. And a little bit about our department is, we are kind of make sure that all of the cases that come in that experienced any type of trauma, that's any type of like fall or a gunshot wound, a laceration, a bruise, anything like that. We just make sure that everything is looking good. And my job in particular is to hopefully help, put our department out of business by preventing those injuries from even taking place, or at least reducing the severity of the injuries. So we have a lot of different initiatives that take place in order to hopefully kind of combat some of those injuries.
And I'm also going to say physical assault because it could be a child abuse, could be a child getting beat up in school. I mean, it's many things. It's many things combined. But I just wanted to also add that the physical part. You opened it by saying it's a level 1 trauma. So for those of us who don't know, what is a level 1 versus a level 2 versus a level 3? You said we're very proudly, you said, Golisano Children's Hospital is a level 1. However, everyone may not know what is a level 1.
Well, yeah, that's a great question. So, a level one, to be verified as a level one trauma center, we need to have, trauma surgeons that are on hand. We also need to have certain like neurosurgical capabilities, orthopedic surgical capabilities, along with a lot of the other specialties. And we have to also be very heavily research focused to constantly strive to find out new better practices, best practices, publish papers and do a lot of research so we can just continue to make it so we provide better health care for as the years go on.
Thank you. Um, what do you feel are the most important things a caregiver, and I say a caregiver because it's not always the mother or the father, it could be many people. So I'm just using the term caregiver. So what do you feel are the most important things a caregiver should know about a child's safety? It's really like a two-part question, beginning with the safety of a newborn, the safety of a toddler, and the safety of a child beginning school, because they're all different levels of developmental age. So what do you feel are the important tips um, caregivers who are listeners in the program should jot down?
I think that's even more than a two-part question,
I-
but no, it's a good one, right? And you touched on a big part of that too, and it's different developmental abilities. So therefore, you have like different risk factors as you go throughout that like continuum of age, right? Um, I think the most important thing, or not it's hard to say what the number one is, but one very important thing, especially with newborns, is for child for the caregivers who might be parents, might be somebody caring for those children, um, is to have a good referral network within. Like so, by just having people that you can call on, because whoever that caregiver is or the primary caregiver, they're going to be tired. There's going to go through stages where yeah, the newborn or the infant is like, might be colicky, might be going through teething, might not be sleeping well, might have some acid reflux, might have some things, and they can't communicate those with you. So I think that just having a good network of people around you is probably, and somebody that you can call on. Is just instrumental in making it so you are your best, you are the best caregiver because you can then get sleep for yourself. That's one thing that's really, really, really important, especially for new parents who or new caregivers who aren't accustomed to that intermittent sleep pattern and things like that. Another really important thing, especially from birth to 4 months of age, but even beyond, is to the sleeping surface. It's not recommended to co-sleep with children, um, and we want to make sure that we have a nice flat surface that is free of different, like everybody or a lot of people, they want to see that, oh, this is where my baby sleeps and there's all these cute things in there, but those cute things can be hazards. You want to keep that as an area for sleeping. You want them to sleep on their back, and you want them to be free of any type of like hazards, even stuffed animals or blankets or anything that they could kind of wrap around themselves. They're just starting to grow, and they don't necessarily, they don't know what their movements can do and what the the repercussions can be from them. So I think that's probably like the couple of really important things in the newborn stage. As you kind of progress into the becoming a toddler, I can say from a parent, being a parent of two kiddos that are, well, a little bit older now, uh,
Right.
but um, but the toddler stage, that is when you as a parent or a caregiver are on your toes, because their physical ability is immense. Like they can run, they can jump, they can do all these things. They're moving in a flash. But the issue is that they don't have the cognitive ability. They don't really know that like the repercussions of their actions. They don't know that like, oh, I can't push on the, or if I push on this screen or something like that, that's not enough to keep me within the household and I could fall from that window. They don't know that they shouldn't put like a finger in an outlet. They don't realize that, there's a possibility like, that they could fall down some stairs and different things like that, or, that if they can't walk on water, and, if they don't know how to swim, that can be a significant hazard. So I think that like the toddler's time is like when you're just on full alert all the way up into the preschool age. And then preschool, it's when you're kind of learning some of the things, teaching road safety, and making sure you're like holding hands, you're looking both ways and then looking again. And, just some of those things. And then, the school institutions, they also really help with molding them to become, have a little bit of a better understanding, which is a great thing. But, as you can see, there's some main topics there that just really, based on the age, can be a little a little trying being a caregiver.
Yeah, and I just want to add couple other things, like when you said birth through 4, because number one, the brain is developing, so they don't know that if that blanket that they have, this new thing that's in the crib or the playpen or wherever you have the child, they don't know if they take this thing and are able to wiggle into it. They don't know that they'll smother because their brain isn't developed yet. They see, or you can't leave a kid in a bathtub alone. I'm sure there are still some of those accidents out there. And then a toddler. Years ago, when Ben and I, and Joe, who's recording this program, were older, when we were younger, television sets were a lot heavier. And most of our listeners, the television set, remember, was a lot heavier. So if you took one hand and pushed it, more than likely, it was on a stand. It wasn't going anywhere. These flat screen TVs, oh yeah, they look good. Your picture is good, but they're a lot lighter. So remember, if a toddler, or if you have twins or quadruplets, if they push on that screen, that one screen, that could fall over on them because televisions are so light, right? Those are my observations. And then toddler, I know a lot of times I observe, people with their children, toddlers crossing in the middle of the street. I know sometimes it is quicker, maybe because, again, I don't have children. It might be quicker to cross in the middle of the street. But for that first grade, that kindergarten student, that first grader, when they run across the street without you, or if they just, cross in the middle of the street, they could get hit. And then they'll be at Golisano Hospital, more than likely. But the whole idea is that you want to begin to teach your children, especially at that age when they are impressionable, good habits, not crossing in the middle of the street. That's not really, and if there's a light, just a couple of steps over. If you can, please cross at the and baby strollers in the middle, so just I don't know, Ben, I'm not the expert, you are.
Yeah. So a couple of things. One other thing to kind of piggyback on to the television conversation is, yeah, I remember I remember TVs. They used to be like, they feel like they weighed a ton. But
Right.
yes, they're very thin. So securing them, wall mounting them, if possible, and then also like when you're talking about, if a lot of times they're on top of like a dresser or something like that, applying furniture straps so that, dressers and things like that won't tip. Because what do young toddlers want to do? They want to climb things. So
Fine.
if they open up one drawer and then they open up another drawer and they're climbing them up, and then next thing you know, that will then tip on top of them. So, it's just one of those things you have to think like, if they're physically capable of doing it, they might just do it. So you just have to really protect yourself, protect the house, and protect that kiddo. And yeah, and it's having kids. I know it helped me also. I didn't necessarily always practice the best safety measures that I could. Um, but we're not going to go into details about that. But after having kids, then I made sure that even if I was going and just doing a little leisurely stroll with my bicycle, that I wore my helmet that was appropriately sized, with them, because you want to lead by example. The whole do as I say, not as I do, that just doesn't work. It's your kids, being a caregiver or parent, like, those young minds, they look up to you, and they will mirror a lot of your behavior. So that's when, they're always watching, and you want to really lead with that best foot forward, and, go and make sure that you're crossing at like a crosswalk or at like a major intersection. Make sure, show them that, well, when this emblem goes, then it's usually like that means that the lights are safe to walk. You still want to make sure that you are looking, because there's a lot of distracted drivers out there. A good thing to keep in mind is, if somebody's allowing you to cross the street, or if somebody's even stopped, making eye contact with the driver is important, because then that's kind of like a nonverbal acknowledgement that they see you, you see them, and that you're able to kind of cross. So just some of those little things can really go a long way.
And one last thing before I move on to the next question. And adults, it's summer, although, however, if this were winter time, it could be kids playing outside. But I guess it's just kids playing outside. My question. My comment is based on children playing outside. If you're pulling out of the driveway and you're backing out with with the back of your car, even though I know there's the newer cars have cameras, you may not see that little person, because it might be short that they may not pick up in your camera. So I would just recommend getting out of your car and just saying, hey, I'm coming out of the driveway, make sure you're out of the way, and still going super slow, because there have been, unfortunately, a couple accidents where people didn't see the kids, and it doesn't always end great. But I just want to make sure that as a caregiver, as an adult, if you see kids, don't assume it's going to be picked up on the camera. Don't assume that they're going to move. Just get out of the car and just say, hey, guys and gals, could you just please, just step to the side for a second, even take a moment and pause. But anyway, um, I just wanted to add that. Child-proofing your home. I always like to ask friends questions. What's something that they would like to know? And someone gave the example of child-proofing a home, meaning putting things on the electrical outlets. So please talk about that. And also, when you're visiting family or friends, should you bring your child-proof tools with them, or ask them if they should get some for their home?
Yeah, it's a couple of good questions there. So when it comes to like childproofing, again, a lot of it's kind of developmentally dependent. It depends if you have a 4-year old opposed to even a 2-year old. Like, there's a pretty significant difference in just ability and things along that line. So. Um, a lot of times, with the younger, just starting to kind of really move around and things like that, and like that toddler age, like that's when you're using a lot of like gates to separate like stairways. You're using little latches to make it so they can't get into any hazardous materials that are like underneath the sink, or you make sure you keep any sharp knives well out of reach, and things along that line. If you have like a swimming pool, you make sure that you have the appropriate latches, have notifications. Some will go ahead and alarm if they have if there's some waves or turbulence in the water. um, there's a lot of different things that are out there. It just depends on the makeup of the environment that you're in and the age of your child. And when you go to like friends or family's house, I remember doing this where, a lot of, like grandparents or great grands or anything like that, like they haven't had to worry about childproofing for quite some time, a lot of times. And so they go, and we used to bring a lot of stuff with us. And the nice thing is, like when they're especially like really young, you bring the pack and plays are just great little areas to know where your young child is, especially for like an infant or a 1 year old or a 2 year old. Um, you place them into the pack and play that you're familiar with. You have your approved items that are located inside, depending on the age and things like that, that they can't get out of, because then that, well, that is baby proofed, you know. And then for other things, it's one of those that you just you bring the appropriate stuff depending on the age of the child, and what developmental age they are or ability they are. So there's no shame in going ahead and bringing your own stuff, especially because you know it and they're familiar with it too. So it'll be a little bit more soothing for them as they're in a different environment.
Oh, okay. Oh, all right. And that was a question I wasn't sure if that, I wasn't sure about that answer. Possibly bring your own things. Um, Now here is a topic that I know I've talked about many times. And as I don't know, what am I? I'm an observer, I'm a consumer. Sometimes I see little kids sitting in front. Sometimes I see someone holding the kid. Sometimes I see little kids strapped in the back of a car facing the driver. Other times I see little kids strapped in a car facing the back of the car. What is the rule on car seats?
Yeah, good question. So generally, well, it's recommended that nobody that's basically below a teenager is in the front seat, and that's just because of a lot of the recommendations and the laws are based on injury patterns that are seen, and depends on like little kids. The smaller they are, they're grown in all the right directions, but their bony structures are not as rigid as that of adults. So it's you want to make sure you're taking that into consideration. Like, these recommendations are there to help keep your kid safe. They're not there to make it so you're not able to have them see the world or anything like that. So the general rule for your car seats, and what's like kind of a law in New York State, is they have to be rear facing till they're at least 2 years old, or if they max out either the height or weight limits of that particular car seat. And then they can switch over to like forward facing once they reach that point. The best practice is to wait until they max out the weight or height. um, and then they can go to a forward facing position, and that will include with the harness system that the seat kind of comes with. It has to be a seat that's capable of going forward. And then finally, you go to a booster seat until you are able to go ahead and sit without any additional restraint. And it's basically when your knees can extend past the seat, your feet can lay flat on the ground, and the shoulder portion of the lap and shoulder belt is not around your neck, and it's firmly across going across your shoulder and your chest. So um, you just think about it. A lot of people think about graduating from one seating position to the next, but you have to take into consideration, at least, that every seating position that you quote unquote graduate to is provides less safety and security than the previous position. So you want to
Mm-hmm.
keep them in, don't be in a hurry to advance them through.
Haha, don't be there like that. Going back to the other question real fast. Are you aware of any grants or any programs that give away, maybe based on income, I'm going to say, give away latches to secure your cabinets or gates for the safety of the child? Are you aware of any programs, let's say based on income that have these things?
Yeah, so there's I know, like, we partnered with Upstate Poison Center, and I know that they work with a lot of different agencies, and they table a lot of events that have these certain latches. ourselves, representatives from the Golisano Children's Hospital here of Buffalo. We table events, and sometimes we go and supply some for like family assistance or family resource centers who already identify those in need. And so the resources are out there, and fortunately, a lot of them don't come at very high price points either. Like some of those basic things that you can do, like the electrical outlet covers. Those are cost pennies a piece, which they don't even make pennies anymore. So that tells you how affordable those are. So there's a lot of things that are out there, and we're of course always willing to help in any way that we can. And we have great like child life specialists, social workers, where if people do come in, or if you see us at tabling at various events around, we try to offer a lot of like household safety items, just because we know that times are tough, and we realize that, I realize that. And so we do try to provide the service, including like helmets, bike helmets, and things like that. So we're out there, and there are resources available. I think going to any of your resource centers located in whatever township or municipality you're in, they also are familiar with the ones that maybe serve that particular area quite well. Or ourselves.
Who would they ask for? Number one, I'm going to ask you for your number, but still, if you're in a town or something, where do you begin? What's the terminology? If someone say is going into their city hall or into their town hall, what title should they ask for?
No, it's a good question. I think it depends a little bit based on the town or city. So like there's a lot of not-for-profits that are available, that kind of work within. I think the schools have
What's the title? But what's the name that they would use? Will they use, is there an injury prevention specialist? Because I want someone to get close to the name. Because a lot of times you walk, and we don't have much time left. A lot of times you'll walk into some place and people are quick to say, I don't know what you're talking about. So we can give our listeners what are some key like you are a trauma injury prevention specialist. So if they're going into a building, what would they ask for? The child prevention specialist? What are a couple of key words they would ask for?
Honestly, though, it really does depend on the organization, and I would kind of go towards like, so that's why I was kind of mentioning like whatever school that they are in or will be in or geographically in. A lot of times, like there's like the social workers would generally be, and they're also going to have a title potentially that's like Family Resource Center, Family Assistance Center. uh there's the Child Advocacy Center.
But
um
one second, because I know we're about to run out of time. If they don't really know, what is your number that they can contact you?
yeah, it's 716
One more time, please.
Yep. 716-323-2624. And I am also like out at different events and different things like that. I don't always have that phone number. I'm not always right by there. So email is a great form of getting hold of me, no matter kind of where I am.
And on that note, I'm going to say I've not asked you for Juneteenth yet, but Ben might be at Juneteenth. And I'm just saying that, Ben, because we were really out of time. And there's always a part two, because we only covered newborns, toddlers, and beginning school year. So we are going to be doing, this is a part one. We'll do a little part two later on, talking about that older child and safety. So Ben, our trauma injury prevention specialist at Golisano Children's Hospital, I want to thank you for being our guest today on the Great Lakes Health Radio program.
Excellent. Thank you.
Oh, thanks. And I'm Francesca Messiah, Manager of Community Health Improvement. And I want to also say that next week or in 2 weeks, you might hear from my esteemed colleague at Erie County Medical Center, and that's Cindy Bass. Thank you for listening. Take care, be safe, and please use some of these tips that Ben was talking about today. And now on to part two. And I want to welcome you back to the Great Lakes Health radio program, where when I see you in the community and you share with me that you heard the program, remember, I'm going to ask you, is there a program you have not heard that you would like for us to address? I should say a topic. Well, let me get started a little bit. Who is Kaleida? I'm just going to go over, because I always get that question in the community. Kaleida Health, we're Western New York's largest hospital system, and we're Buffalo General Medical Center, Gates Vascular Institute, Golisano Children's Hospital, Millard Fillmore Suburban, the Visiting Nursing Association that provides care for newborns all the way through the last days of your life at your home. We have clinics located throughout Western New York for adults, for children, specialty clinics. We have also 2 long-term care facilities. That's DeGraff Long-Term Care in North Tonawanda, and High Point here in Buffalo, High Point in Michigan, at the corner of High and Michigan. I could go on and on about Kaleida Health, and I know you've heard me, and I'll do that next time because our topic today is we may have a part two. We haven't even started, right? But we might have to have a part two. Our topic for today, breast cancer and treatments. And our guest is Dr. Stuti J. Tambar, physician and also a breast care surgeon. Good morning, Dr. Tambar. How are you?
Good morning, Francesca. Thank you so much for having me today.
Oh, you're welcome. And Dr. Tambar, there are not many female surgeons. And my question is, briefly, in medical school, what led you to focus on surgery?
Oh, Francesca, when I started medical school, I thought maybe I'll do pediatrics or GYN. But when I started my clinicals, which was third year, I just fell in love with surgery. I was there actively repairing patients' pathology and making a change in their life on a very quick turnaround. So I just love that part that I was in control and taking care of my patients, and they would come in sick and they would leave a few days later happy and completely treated. So that satisfaction was just amazing for me. And that's what led me to choose surgery.
That is so wonderful because, and again, I always, having worked on the workforce side of Kaleida, I always like people to hear about careers, and being a physician is a career path, and being a surgeon is a specialty within that career path. So I wanted to share that. On to breast cancer, which is near and dear to my heart because my sister passed away of breast cancer, and there's just so many unknowns. And it's not about me, it's about the community, it's about the public, it's about women of color, and breast cancer. So, how is breast cancer diagnosed? Is it something you can see on yourself that you have breast cancer?
So the breast cancer is diagnosed in 2 primary ways. One is where patient has symptoms. So you may see changes in your breast, not so much pain. The cancer actually doesn't hurt. So it's usually a mass that suddenly appears one day when when you're examining yourself, or most of the time when people are showering. It could be a nipple discharge, like blood coming out of your nipple, skin changes that were just not there before, just hardening of the breast, sometimes shrinking of the breast. So those are some of the symptoms that patients may come in with that would indicate cancer. More and more commonly, we are seeing patients diagnosed on screening mammograms. So they had no complaints, just routine exam, and there's a small finding on a screening mammogram that leads to diagnosis of cancer. Honestly, the finding on screening tends to be smaller, more early stage. So that is definitely a better way to be diagnosed. but we see both types of patient being diagnosed either through symptoms or through routine screenings.
And ladies, you have to stop and look at your breast. Most of us wear bras, and so it's not just about putting on your bra every day. It is about that, but it's also about checking, as Dr. Tambar just said, nipple discharge, skin, was it skin discoloration? Was it that you said?
Yeah, it could be skin change, like skin dimpling. It could be hardening of the skin. It could be darkening of the skin. It could be skin turns a little irritated looking, like orange or red in color that doesn't get better with antibiotic treatments. Those are some concerning signs of cancer.
And then a lump. You said a lump, like I know we talked about breast cancer. Well, but people always talk about breast self-screening. So you said it could. Now, where would you feel this mass in your breast?
So, breast cancer can start anywhere in the breast, from in any quadrant. If you were to divide the breast into four pieces, if you draw like a plus sign on your breast, so there's four quadrants, and cancer can appear in any of those four. So, really, once a month, we do recommend women check their breast every single quadrant, just trying to feel for any masses.
Okay, thank you. So ladies, please, everything here is important today. Screening. How important is screening? And there are so many things now, information that says when should a woman begin screening for breast cancer?
Screening for breast cancer is very important and critical in diagnosing an early stage cancer, because by the time women start to feel symptoms or masses, the cancer may have been growing for a little bit longer. So screening picks up small, I'm talking like millimeters, 2 millimeters, 3 millimeters cancer, which is about size of a third of an apple seed. So these are picked up on screening images. So screening is extremely important. Usually we start at the age of 40, and that's like the first mammogram, and then every year after that.
Mm-hmm. And then, so what if someone's family member has had cancer? Does screening matter, or is it only certain types of screening? If someone in your family has had, like, do all cancers tie back to breast cancers, or does just breast cancer tie into breast cancer?
In addition to breast, there's ovarian, uterine cancer that could also be tied back to higher risk of breast cancer. So we usually do take family history when patients comes in with any complaint of their breast, and any first and second degree relative with the breast cancer. So your parents, grandparents, aunts or uncles on either side of the family, siblings, children, all of that matters. And if there is a pattern of early cancers or more aggressive cancers, a patient would be eligible for starting screening earlier, about 10 years before the youngest member's diagnosis. So if an aunt was 50 when they got diagnosed, they would start at 40, which is a normal age. But if they were diagnosed at 40, they would actually start your screening at 30. And in addition to that, we also add breast MRI, which looks at breast in a different way. And we just look at the breast twice a year with mammograms and MRI.
How about if is someone, like, for lack of better words, who's more flat chested, less likely to get breast cancer than someone who has a larger chest? Does chest size have anything to do with cancer?
Not really. I don't believe there's a study that shares that there's a reduced risk of cancer in women with smaller breast. I mean, just by the sheer volume, there's more of breast tissue to something for to go wrong. You can kind of put it that way, but again, there's no data, no research that shows that women with bigger breasts had higher risk of cancer than women with smaller breast.
Okay. I just wanted to, make sure people didn't think that was something that was true.
Yeah,
Speaking.
and regardless of the chest size, we do mammograms. I mean, we do mammograms on men who come in with any breast complaints. So regardless of breast size, women are eligible for mammograms. Sometimes women say, "Well, my breast is too small and I'm not going to fit in there. What's the point? I'm not going to go." We actually will do mammogram, and it's effective.
Mm-hmm. Um, when we talk about breast cancer rates have decreased, all the information I've been reading it says that breast cancer has decreased. However, the rates for African American women have not. And is that true that the rates of breast cancer for African American women have not gone down?
So, research has shown that African American women present with more advanced stage of cancer at the time of diagnosis, and they tend to present with more aggressive cancer. And that has not changed. It's because the Caucasian population is at the higher risk of breast cancer, but they tend to be not as aggressive, present at a later age. But for African American, it tends to be, like I said, earlier age, more aggressive, higher stage cancer, and that has not been changed. It's hard to say why the rates are not going down.
So when you talk about more advanced, what does that mean? More those words, advanced, aggressive. What
Oh,
do those words
advanced,
mean?
sure. So in terms of staging, there's stage one, two, three, or four. And so the advanced stage would mean that the stage is not one, it may be two or three. Those patients tend to need more aggressive treatments. Tend to need chemotherapy at a more frequent rate than women with a stage one cancer. They may be more aggressive, as in the sense they may grow faster than some of the other cancers of the breast. So that's a difference between an advanced stage and an advanced cancer, or aggressive cancer.
So how fast if someone is diagnosed with breast cancer, and let's say we'll talk, what is the stage two? And if someone is advanced, I mean, has stage one or stage two, is that something, breast cancer, is that something they should pay attention to, or are they okay because it's not stage four?
Yeah, so I mean, staging again changes the treatment plan. It doesn't really change um, what patient information we give. So because there's national standard guidelines for treatment of breast cancer of different stages. So the treatment offered is same across the country. But what really changes is the prognosis. There's a higher rate of recurrence with a higher stage of breast cancer at the time of diagnosis. So a woman with a stage one cancer may have 4 to 6% risk of recurrence, versus a woman who's stage two or stage three would have a significantly higher rate of recurrence in the future. So that's what really changes. I mean, regardless of their stage, we still do curative treatment. We still do surveillance for 10 plus years to keep a close eye on them, on their breast. So it is very regimented in terms of how we follow those patients after they have completed treatment and the cancer goes in remission.
And at what point, like I know sometimes people will say, "Oh, it's not bad. I just have chemo and radiation," and then sometimes people say, "I don't know, they have something else, but then they have to have reconstructive surgery." How does all that work with a diagnosis? Is somebody with stage one, let's say, do they have chemo where stage two would have chemo and radiation? I'm just trying to understand the terms that survivors, I'm going to say that survivors have referred to, because you don't always want to ask people a lot of questions. So what exactly does chemo and radiation and reconstruct, what does that mean when it comes to your breast cancer?
So the reconstructive surgery is available to all women of all stages, stage one, two, three, because we are looking at curative disease. So I have had women who underwent double mastectomy, as in both breasts were removed, and they had reconstructive surgery when they had a 2 millimeter cancer. And I've had women who wanted to save their breast and only removed the part of the cancer when they had a 5 centimeter cancer. So it really comes down to what women want. Chemo is generally reserved for, I would say, at least a stage two cancer. There are very few women with stage one cancer who need chemo. And radiation is something that a lot of women end up needing, because anytime you save the breast, like do a lumpectomy and not remove the entire breast, women end up needing radiation. So they're all very different parts of the treatment, different ways, different approaches to treat the breast cancer.
And because you mentioned stage 1, 2, and 3, so it's stage 4. Normally, it's something that reconstructive isn't considered.
Usually because stage 4 is metastatic, as it has gone outside of the breast and lymph node. It's somewhere in the bones or the lungs or the liver or another organ of the body. So it's no longer curable. So at that time, we usually provide palliative treatment, which is basically control the disease. And women live on palliative treatment for decades at times. So it's not a death sentence. It's basically saying we cannot get rid of your cancer entirely, but we will control it. Most of the time women end up not having surgery in that case because surgery is an invasive procedure, and we offer it when there is a curative intent. That being said, I mean, I do mastectomies or lumpectomies for women who are stage 4 and they just want to get rid of this cancer because it's a reminder sitting every day that they look at that they have cancer. So, but that's not with a curative intent.
Mm-hmm. Is it? Are there ever patients who go from stage 1 to stage 4 in a year? Can that ever happen?
I would say no, thankfully. We don't have breast cancer doesn't move like that for sure. It could be that, when I saw them the first time, we only had a mammogram, but when I saw them the second time, we had more studies and we just didn't have all the information and they were actually stage 4. But the patient does not go from a stage 1 to a stage 4 within a year or something like that. That's highly uncommon, I would say.
Mm-hmm. How about someone over 80? And the reason I just use the age 80, because I know sometimes after women stop having periods, or after, or they're no longer bearing children, that they may not go for a pap smear. Um, Women over 80 can if you're over 80, can you still get breast cancer? And I just put 80. It could be over 90. I just threw 80 as an arbitrary number because it's 20 years from 100. So there was no real rhyme or reason.
Sure. One of the biggest risk factor for breast cancer is age. So as we get older, our risk of breast cancer increases. So I
Really?
frequently have women in their 80s, even 90s, who present with their breast cancer, and they haven't had a mammogram in 20 years because, they're 90. So we actually recommend continue mammogram until your life expectancy drops less than 10 years. And again, this is a guess that's an educated guess that you and your primary care provider or a GYN made, that, you probably have less than 10 years left. Then we don't need to do the mammogram. But I mean, we are living longer. We are eating better. We are healthier. We want to take care of ourselves. And women are living longer and longer. I mean, my oldest patient at this time is 98. So we are, as we live longer, we have to take care of those breasts and all the organs, but especially breast, a little longer.
I have to say, if I was given a test or asked for $100, if I would have gotten it wrong. I would have thought the older you get, the least likely you are. Well, I guess, yeah, I don't know why I would have thought the least likely you are to have breast cancer, but you're saying the older you are, the more likely you are to possibly have it. So that's why
Correct.
screenings are. Oh my
Yeah. Yeah.
gosh.
Age is one of the risk factors. Older we get, the higher the risk of cancer. So, like I said, I mean, until your life expectancy drops below 10 years, continue having that mammograms every year.
Amazing. That really is amazing. Something you said just triggered a thought. I know, gosh, you know what? That that question it really just threw me off because of the age. And what's something you would like to share with our listeners that we've not talked about this morning?
I mean, the other thing we can definitely bring up is genetic testing. Only about 10% or less of cancer in breast is associated with a genetic mutation, but we're seeing more and more patterns of families with cancer at every generation. So as we start talking and you notice seems to be a lot of cancer in the family, discuss that with your primary care, your GYN, and do a genetic testing because a lot of time when women have genetic mutation, they are at risk for more than one organ to become cancer. For example, the BRCA1 gene, which is a little bit more well known, Angelina Jolie had it. She removed her breast and ovaries preemptively. So that cancer is associated with breast and ovarian. There are some cancer there's a mutation that have breast and thyroid cancer risk. Some have breast and pancreatic cancer risk, breast and colon cancer risk. So there's a lot of organs, and one of the one of the common misconception I see is a man doesn't need genetic testing because a man doesn't have breast, but a man does have the pancreas and the thyroid and the colon. And I mean, instead of ovaries, they have, they have prostate cancer that could be of risk. So they have a lot of other organs that could turn cancer. So men and women equally need to be tested when there is a pattern of cancer in the family.
And let's talk a little bit about genetic testing. What exactly does that mean?
Genetic testing is basically taking a tube of your blood and sending it to the genetic testing facilities where they test for about 36 gene mutations associated with breast cancer. And again, not everybody has family history or risk of breast cancer. You may have risk of other types of cancer, and their genetic testing that is suitable for every patient is tailored to your needs. So there are genetic testing specific for people who have a lot of colon cancer in the family. So then they have Lynch syndrome and many other syndromes that are associated with colon cancer and at younger age. So then you'll be tested for those list of genetic mutations. So it's really important to talk with the family and find out what risk you have, if there's any pattern. A lot of time families don't know what the risk is because they're estranged. But sometimes it really helps to at least have that history and write it down somewhere so you don't have to keep asking for it. But knowing our risk is our best weapon against cancer.
Mm-hmm. Thank you. And I remembered what the question was because you mentioned colon cancer, diet. Are there certain things you are aware of that to prevent, let's say, breast cancer that women and men should avoid or reduce, limit?
There's not a whole lot of nutrition-based cancer risk reduction, as in there's nothing you can eat or avoid eating that will reduce breast cancer. There's some anecdotal data on sugars that maybe if you reduce sugar, that will reduce the risk of breast cancer, but it's never really been proven. One lifestyle factor that has shown to reduce risk of cancer is just having a healthy body weight, exercising, staying active, overall general well-being, I believe, is beneficial for preventing all cancers. So that is something that I tell all my patients, healthy lifestyle. You don't have to become, a gym rat, but something regular that you can do. I mean, again, some people can do once a week or twice a week, and that's enough as long as you're consistent.
Mm-hmm. Or you don't have to run every single day of the year.
Exactly.
Yeah. Yes. Okay. Yeah, no, that was the I think I asked all my guests here on the radio program about diet as it and health. Overall, your overall health and well-being as it ties into different topics. So that's why I asked that question. But you're saying there's more research possibly to be done in that area on food and let's say breast cancer?
Correct. There are studies going on. Even in our institute, we're looking at some low sugar, low carb diet to see the effect of it. But again, these are long-term studies because we have to follow these patients for decades to see if they develop any cancer. So the data may not be available for some of our listeners to make any meaningful impact. So. But I believe I personally believe in healthy lifestyle, healthy nutrition, healthy diet, healthy exercise program to prevent risk of breast cancer and really all cancers.
Yeah, thank you. If somebody wanted to, now, how would someone see you? Are they referred to you or would they make an appointment to see you? How, if someone's interested and they have some concerns?
Sure. Yeah, we actually run a high risk clinic where patients who are known to have high risk for breast cancer based on either family history or their personal factors, they are followed twice a year for review of images, which includes mammograms and MRIs, and do a clinical breast exam. So if anybody wanted to see us, they can either be referred to their primary care providers or GYN. And some insurances don't require referral, so you can just make a direct appointment in our office.
And do you have a number for someone to call your office?
Yes, so it will be 422-0010, area code 716. That's a direct number to our office.
And if you could say it one more time, because someone pen just ran out of it.
Sure. 716-422-0010.
Oh boy. Thank you. So thank you, Dr. Tambar. But I just want to say that I know they say that what month? February? Is it no, September is breast cancer month or October?
October, but really every month is breast cancer month for me.
And
So.
that's exactly why I say, listeners, that's why we're having this program, because every month is breast cancer month. There is no one month where someone is diagnosed, because I don't know. Do you know how often a woman is diagnosed or a man with breast cancer?
So men have low rates of breast cancer, but the women, 1 in 8 women are diagnosed with breast cancer. So there's about 12 to 13% risk in every woman with no risk factors of developing breast cancer. If you have risk, that risk goes up from the 12 and 13. Anybody over 20% lifetime risk of breast cancer is considered high risk.
And you know, that again, that's why we have this show, just to talk about the importance of screening. How important is screening, Dr. Tambar?
Extremely important. It's a way of a healthy lifestyle.
Yes. Thank you. And one thing I always say, if you're afraid to get screened, you know, or afraid to make your mammography, call your friend, but don't call her the day of, or him. Don't call them the day of the appointment. Give them a couple of weeks. Get your appointment first, then call the person a few weeks in advance to see if they can come with you. And do something fun after, like go for lunch, sit by the water, go for a walk. It's not stressful. It should not be stressful. It's healthy.
Yeah, and we have a lot of patients who kind of have their mammograms all scheduled on the same day, friends or group of women, and they all go together, get their mammograms done, and go have lunch or dinner, and then they kind of use that as one day of the year that they take care of themselves and celebrate together.
That's one, or go for mani-pedi.
Mani-pedi, there you go.
Something. Well, Dr. Tambar, we are out of time, and I want to say I will probably be calling you back in another few months as we get closer to October. Time flies. So I want to thank you for we've been speaking this morning with Dr. Studi J. Tambar, physician, breast cancer surgeon at Kaleida Health, and general physicians, right?
Correct.
And general physicians. So I want to thank you, Dr. Tambar, for being our guest this morning on the Great Lakes Health Radio program.
Thank you so much for having me.
You're welcome. Thank you, listeners. Bye-bye.